because you have to go. So retinal hemangioma, as you know, it's associated with some disease like renal cell carcinoma, pheochromocytoma, and it's mostly inherited from a parent, typically in a germline and somatic in a rare formal types. What we should remember to make it easy, that management, you have to classify it to 3 categories: less than 1.5, above than 3.5, and those less than 1.5 the size, you can treat it with laser easily. Above 3.5 or 4.5, you will get obligated to use a surgical rather than laser. In between, you will use whatever you want, and there will be some percentage of them will not be closed or treated easily, like photodynamic therapy, laser, and cryotherapy, and even brachytherapy. You can use it for those cases. So surgical management of a large extrapapillary retinal hemangioma. Sometimes some of the literature show that the scleral buckle, but just put in your mind, those are a hemangioma and a vessel that extended everywhere. Sometimes when you do the scleral buckle, you close those vessels, causing congestion in the other side, and this will lead to either red eye or a congested conjunctiva. Dithermy, ligation of the feeder vessel by surgery, this is also one of the options. So this is the video in which, as I told you, we published one of the cases. It associated with a severe BVR after scleral buckle, because with those BVR, sometimes you don't want to go inside. But you will be surprised that even though a small manipulation of those disease can stimulate a lot of inflammation, cause a severe BVR. And there is another publication about the metabolic disease. Metabolic disease or a genetic disease, they have immature immune system, and touching those cases cause a lot of BVR should be considered. Of course, in those type, you should do a bimanual technique, and chandelier is a must for those procedure. Sometimes I like to have either 2 different forceps, like ILM forceps and a serrated forceps. I don't want to make them together in both hands, because you can alternate between them if you don't want to have a Caesar and a forceps, which is more safer for those cases. PFCL, even though it's controversial in some countries, we still use it and we find it very helpful. And continue dissecting the BVR and excising those a tumor from the eye is very important. And as you see, retinectomy sometimes is very useful to flatten the retina. Otherwise, it will become very difficult to flatten the retina in those cases. Whenever you prioritized excision is more important than ligation, more important than burning by cryotherapy or a laser. So excision is the priority. Doing silicone exchange directly with the PFCL, avoiding the slippage, is also very important. And you see, even from behind the retina, I'm trying to eat whatever hemangioma or choroidal vessel at that time, so we can have a good flattening of the retina. Is also one of the techniques that you should be put it in your mind, flattening the retina, and that's it.
Thank you very much, Dr. Abdullah. I have one question for you. Do you still have PDT in Saudi Arabia?
It's a very good question. Unfortunately, the material, as you know, the Visiodine is out of the market. It has been purchased by, it was owned by Bush & Lomb, then purchased by Novartis, and you know the competition between the injection and the Visiodine photodynamic therapy. So it was vanished from the market in most of the time.
So it's not available anymore?
It's in my hospital, it's not available.
Okay. Any
I don't know if someone, Dr. Ahmed.
Yeah, we have it available, but I think PDT for hemangioma is a flashing event. I think it's talked about. It doesn't work very well. I think what works very well for hemangioma is plaque, and it's a very, very small dose. It's not like the melanoma where you get side effects. So if it's like a peripheral one, I think Lux works very well.
You mean the brachytherapy? Yeah. Actually, this is true if the size is above 3.5. And there is a European consensus of that actually. Less than 1.5, definitely photodynamic therapy is safer, simple, and easy to be repeated because photodynamic therapy is not one shot. Actually, it's a session. You do it now, you see the patient after 3 months. If he need, you do it again, then 6 months and set.
Ahmed, what would you do about the posterior located ones and the peripapillary ones?
We have
Yes.
We still have PDT, and we do PDT for them, but the large one in the periphery, you can try this one. What really works is, it's, I think Abdullah saying it's a small dose, and it works very well. It's different for melanoma. I think you can try. The other thing is the medication. The name is slipping my mind. That's a new one. Yes, that's
Yes, and unfortunately in the US the patient has to have systemic disease like CNS to have the medicine, and it works very well. We have 2 cases that did fantastic. I can't remember the name really, but there's a medication if they have CNS.
Yahya?
Thank you, Abdullah. So the main issue usually from the peripheral hemangiomas that's almost leak. The juxtapapillary one, they are almost very benign. They don't leak. If they leak, then you can treat with BDT. I think this is the best option for them. For the peripheral hemangioma, it's not only for the isolated tumors. Sometimes you have to keep the von Hippel-Lindau in your mind, and those patients usually they have multiple hemangiomas. So you need to screen them every now and then. They keep develop hemangioma every now and then, up to the age of 35 or 40, and then the development of hemangioma start to wean off.
It's very good comment, Dr. Hassan, Yahya, and we should send the patient for MRI with contrast to rule out, as you said, any other. And now our next speaker is Dr. Zaid, Traumatic GRT Management.
Right.